Hi, my name is Bruno Medeiros from Stanford University, and it's a great pleasure to present the highlights of our abstract selected for oral presentation at the 2016 ASH meeting in San Diego. The abstract was entitled Analysis of Efficacy by Age for Patients Aged 60 to 75 with Untreated Secondary Acute Myeloid Leukemia treated with CPX-351 Liposomal Injection versus Conventional Cytarabine and Daunorubicin, a Phase 3 trial. As a means of an introduction, CPX is a liposomal formulation of cytarabine and daunorubicin that is encapsulated to maintain a 5:1 molar ratio. This fixed molar ratio is maintained in human plasma up to 24 hours after completion of the last dose of the medication. This allows for an increased dose exposure that is maintained for approximately 7 days after completion of therapy, and this also is known to lead to selective uptake of CPX-351 by leukemic cells compared to normal hematopoietic cells in leukemic-bearing mice. Following some successful early-stage development of this compound, Celator, the sponsor, designed a Phase 3 open-label randomized clinical trial with a 1-to-1 randomization where patients were randomized to receive CPX-351 or conventional 7+3 induction chemotherapy with cytarabine and daunorubicin. Key eligibility criteria for the study included patients being previously untreated, ages 60 to 75, deemed eligible to receive induction chemotherapy, and with a good performance status. In addition, 2 other stratifications occurred. Patients needed to have 1 of 5 high-risk features, including the presence of therapy-related acute myeloid leukemia, AML with a history of myelodysplastic syndrome with or without prior therapy with a hypomethylating agent, AML with a history of chronic myelomonocytic leukemia, or de novo acute myeloid leukemia with an MDS-associated karyotype. In addition, patients were also stratified at the time of randomization to 2 different age strata, 60 to 69 or 70 to 75. Patients received 1 or 2 cycles of induction chemotherapy. Those achieving a complete remission could receive up to 2 cycles of consolidation, and transplants were used at the discretion of the investigator. These are the baseline characteristics for the patients enrolled in this trial according to age strata. As you can see from the table, there's a pretty good distribution of these patients between the 2 age strata as well as in the 2 arms according to age strata, without a lot of imbalances in these groups. In general, 200 patients were enrolled in the 60 to 69 stratum, a little over 100 patients enrolled in the older age stratum between 70 and 75. The primary endpoint of the study was the median overall survival, and here you have those data, both for patients between 60 and 69 and those 70 to 75. Randomization to CPX was associated with an improvement in the median overall survival. For example, for patients between 60 and 69, CPX randomization led to a median overall survival of 9.6 months versus 6.9 months for the patients randomized to 7+3, with a 32% reduction in the risk of death. For older patients, randomization to CPX led to a median survival of 8.9 months, with a 45% reduction in the risk of death, hazard ratio of 0.55. In the next slide, we looked at the overall response rate and complete response rate according to age strata. As you can see from this graph, those patients randomized to CPX in both age strata had similar improvement in the CR or CR plus CRI rate, with odds ratios that were very close to reaching statistical significance, especially for the young age stratum. The differences were similar for the older patients, although the differences did not reach statistical significance. We looked at the 30 and 60-day mortality, and what can be depicted here is that randomization to CPX was associated with a numerically decrease in the 30 and 60-day mortality, both for younger and older patients. Worthwhile mentioning that patients randomized to 7+3 had almost doubling of the 60-day mortality in the older age stratum compared to those patients randomized to CPX-351. We did perform an exploratory analysis looking at the impact of allogeneic stem cell transplant according to age stratum for the younger patients between the ages of 60 and 69 A little over 30% of the patients in each group was able to receive an allogeneic stem cell transplant, but the benefit of transplant appeared to be significantly greater for those patients randomized to CPX-351 with a median survival not reached, compared to 12.1 months in those patients randomized to 7 and 3, hazard ratio of 0.50. For the older cohort of patients, a significantly greater percentage of patients randomized to CPX were able to transition to transplant, 28 versus 11%, with a similar improvement in the survival post-transplant not reached for patients randomized to CPX, and 6.6 months for those randomized to 7 and 3. We concluded that in the subgroup analysis, patients aged 60 to 69 and 70 to 75 with untreated secondary AML, treatment with CPX was associated with a significantly greater median overall survival, higher response rates, higher rates of allogeneic stem cell transplant, and an exploratory analysis, an improvement in the median overall survival following transplant. That concludes our presentations. I would like to thank the audience very much for listening in and allowing me to share our data. Thank you. Bye-bye.